Morning, Kristen. I'm just checking my audio and video.
Sounds good.
Right. And is Maggie the court reporter again today?
Michelle.
Michelle, are you here?
Go. Sorry about that. I was muted.
Problem. Nice
Can
to meet
you
you.
hear me now? Can you see me now? Okay, here we go. Sorry, I'm looking
Yep, you're
sideways
good.
because you guys are over there. Over here.
Can see you and hear you.
Okay, perfect.
Morning, Mr. D.
Good morning. Can you hear
You.
me okay?
Yep.
Much, okay. Thank
Yes.
you. Okay, thanks.
And do you have everyone from your team?
I think they're on, I'm not seeing the faces, but let me just check real quick. Bob, are you on?
Good morning, I'm here.
Okay. And, okay, and I'm assuming, Trey, are you there too?
I'm here, Tom. Your camera might need to come down just a bit.
Okay, thank you.
There you go. There you go.
Thanks.
Oops. Okay.
And I see Mike Fisher. Is Mike Del Treco here?
Yep, Mike, both mics.
I see.
Yep, I am Chair Foster. Thank you. And I assume you can
Right.
hear me.
Yes, sir.
Thank you.
Do we have a hearing officer today or no? Not
Yeah,
considered.
I will be Michelle.
You will be? Okay. All right.
Yeah, it's not a hearing officer for this. I'll chair the meeting and run the meeting.
Gotcha.
And last but not least, Miss Barabee, are you here?
I am.
Great. Hey, Michelle, we can go on the record.
Okay. 1 second. Here we go. All right. We're on the record.
Morning. I'll call to order the Green Mountain Care Board's hearings of August 7th, 2024. We have 3 hospitals presenting their budgets for fiscal year 25. Southwestern Vermont Medical Center, Copley Hospital, and Rutland Regional Medical Center. Before we start, we'll have remarks from the Vermont Association of Hospitals and Health Systems, and also from the Vermont Healthcare Advocate. And with that, I'll turn it to Mr. Del Treco from the Vermont Association of Hospitals and Health Systems for his opening remarks.
Thank you, Chair Foster. Good morning, everyone, board members and members of the public. First, I want to start by thanking the board, Elena and her team for the work leading up to these presentations, and members of the public for being here today. And on behalf of all Vermont's not-for-profit hospitals, thank you for allowing me to comment on these 2025 budgets. Before I get into my comments, I think it's also important to acknowledge and thank every single hospital employee across the state that helps get the job done every day. I want them to know from me and my team at VAS how important they are to Vermont and their communities. As we are all deeply familiar, our hospitals have been under great pressure over the last few years and intensely understand the pressures facing Vermonters and the healthcare delivery systems. We know that access challenges Vermonters are facing to get in to see their primary care doctor or get a specialty appointment are concerning. The lack of mental health, long-term care, and substance use services, to name a few, impact the health of Vermonters every day. The affordability pressures from high insurance premiums, copays and deductibles, and rising hospital costs impact choice. The sweeping financial challenges that both hospitals and insurers are managing are real. Unfortunately, there are no quick answers or solutions. But as we examine hospital budgets, we must continue to understand the impact that Vermont's landscape and demographics have on our circumstances. We are old, we are rural, and we are small. All of these things impact our economies of scale. We have increasing utilization and acuity of care needs, housing pressures, and flat economic growth. These all go into the complex healthcare equation. Even with these challenges, I am pleased to say that hospitals have submitted responsible and carefully crafted budgets centering on patient care needs, with critical investments in staff, facilities, and equipment, while also recognizing cost pressures Vermonters are facing. Very importantly, these budgets have been submitted, represent significant progress towards stabilization, and demonstrate a clear and strong message to our communities that hospitals have leaned in on the issue of affordability. Overall, the system rate increase ranges from 2.2% to 10.5%, with a weighted average of approximately 6.4%. This is down 40% from 2024 approved amounts and in line with stubborn inflationary pressures. It's important to remember when reviewing these budgets that they're about people. We are a 24/7, 365-day-a-year operation that require a highly skilled workforce. In fact, 60% of our budgets go to support these amazing teams. The submitted operating margin of 2.3% is a move towards stabilization. However, we know these margins need to be higher so we can appropriately invest in systematic change while caring for our communities. Even with these pressures, Vermont continues to rank in the top 5 states in the Independent Commonwealth Report that measures many dimensions of healthcare, such as quality, access, and equity. And although we are deeply challenged with affordability issues, Vermont has one of the highest insured rates of 96+ percentage points. These budgets are about moving forward. As we do, we will focus and continue to work on the positive and stabilizing trajectory. We are continuing and committed to examining opportunities to do better. More importantly, we are dedicated to a transparent stakeholder engagement, working with you and the Green Mountain Care Board staff, AHS, and others. If there are opportunities to do better, we should understand the details, the benefits, the possible unintended consequences, as well as the necessary and best ways to move forward. At the same time, we have to account for external budget pressures that in many instances can be beyond our control. Once again, to address these issues, we require ongoing partnership opportunities to work together to help limit the impacts on future budgets while improving system outcomes. We must work to improve the greater healthcare ecosystem. VAS applauds AHS in their initiatives to increase access to long-term care and mental health. This is an important step forward, but again, there's more work to do here. We must improve housing and transportation. These two factors alone threaten every aspect of healthy communities. They make recruiting workforce challenging, and they tamp down economic growth opportunities. We must improve the financial policy positions such as DISH funding, provider tax, and cost shift issues. To be more specific, DISH. Vermont does not take advantage of federal disproportionate share payments that they could. Our federal funding cap is $47 million, yet annually we use about $22 million. From fiscal year 23 to 24, we have a lost revenue opportunity of $144 million. We need to maximize federal funding. This would both help hospitals and create relief on commercial insurance. Provider tax spending. Vermont's 6% provider tax equals approximately $200 million on hospitals. That, along with federal matching dollars, cover 100% of hospital Medicaid reimbursement and provide other funding opportunities for state investments. A review of the provider tax should take place to determine if there is the ability to increase Medicaid rates, to put downward pressure on the cost shift, and improve access to services. Cost shift. The annual Green Mountain Care Report on the cost shift identifies that in 2023, the Medicaid and Medicare underfunding totaled $582 million. This is a significant financial burden both on providers and insurers. As we explore new state and federal payment models, it's imperative that this be addressed. Vermont can no longer afford to do business this way. And finally, I want to circle back to where I started. Although I'm cautiously optimistic that we are making forward progress and are in a better place today since any point from the pandemic, we do know that the road ahead is very challenging, and the simple fact there's a lot more work to do. I know that my members and I am committed to doing the work, and I ask the board to support these budgets so our hospitals continue their efforts to stabilize and meet their community needs. We need critical resources so we can get this work done on the road ahead. I really appreciate the time here, Chair Foster, and thank you.
Thank you very much for those comments. Mr. Fisher.
Good morning. Good morning, Chair Foster and members of the board. I appreciate having a few moments to speak to you as you launch into this next significant phase that is the annual summer regulation, hospital budgets. I don't need to spend any time reminding you, you all know the perfect storm we're in. We spent a lot of time recently looking at the impacts of this perfect storm on our insurance carriers. We are about to spend a decent amount of time, a lot of time, looking at how this perfect storm is affecting our hospitals. And I know you know how this storm is affecting Vermonters, the consumer affordability challenges. So this is hard. This is going to be hard. I just want to pause and recognize that. I should also pause and I want to echo what Mike Del Trecco just said about recognizing and appreciating not only the hospital leaderships that will come before you over the next couple of weeks, but also the people on the front line providing care. Super important. It's what we're all here for, after all. You've heard me over previous years talk about the ratio of bad debt to free care, and I'm going to do it a little bit again. The last year for which we have full data, 2023, the range of how hospitals are doing in that ratio goes from 1 to 1, that's UVM. For every dollar of free care they gave out, $1 of bad debt or medical debt went to people who got care. To a low on the other side of 7 to 1 or 1 to 7 for every dollar of free care, a little over $7.22 went to medical debt for people in their community, for people they served. I'm not going to name that hospital. So I have over the years asked this question, and I continue to ask it: what is it that leads to that variation? The most obvious answer to that is a difference in the relative generosity of those two hospitals. That's what we're seeking to address with Act 119. You heard a presentation about Act 119 a number of months ago from members of my team. It went into effect on July 1st, and it seeks to normalize for it creates a statewide minimum for free care policies in an attempt to find a balance, find a way to apply a system across the state. So briefly, Act 119, the effort to help hospitals comply with Act 119 has been a major effort of the HCA over the last year. We're really trying to support hospitals in providing the community benefit that they need to provide to their communities. And on a high level, good job. Hospitals have done a good job across the system in complying with the law and, and in not stepping back from their effort to provide real benefit to their communities. That doesn't mean there aren't some weak points. There are quite a few hospitals that have had a challenge in complying, and we will spend some time hospital by hospital recognizing some of those challenges and successes as hospitals come before you. We're going to stay on it. We are staying on a relatively high level this year. The law is complex. There's many, many pieces to it. We're not going into the depths of it. We're staying on a high level of, have hospitals satisfied the plain language summary requirements? How are they measuring income and verifying income for people in their community who are seeking free care? Asset test compliance and residency and those kinds of things. Now shifting back over to the process in front of you. We recognize in looking at the submissions this year that some hospitals have demonstrated a real ability to cut costs by reducing administration, collaborating with other hospitals, partnering with community organizations to meet their community's needs. And we want to recognize that, and we'll recognize that as hospitals come before you. We also recognize and understand the board's interest in looking at a lot of details about the hospitals in front of you, hospital quality, provider productivity. I understand and support the effort to gain a better understanding of what is going on in our hospital system. But I also think it's important to say here that we think it's important to remain focused on what you can do and to address, as I said, the storm in front of us. And that is hospital prices and hospital costs. The HCA doesn't arrive at these hearings with an NPR or commercial rate recommendation for any hospital. And I don't think the board should either. It's, we certainly support hospitals' rights or the importance of them coming before you to make their case. We can certainly see circumstances where that would lead us to recommend or support a hospital receive an NPR that exceeds the guidance. We can also see circumstances where we think it would be right for the board to decide to reduce a hospital's commercial rate even below the cap in the guidance. We can see scenarios where it would be reasonable for the board to deny a hospital's commercial rate if there is insufficient evidence in the record to support it. Overall, the effort in front of us, as we understand it, is to address the perfect storm and to do what you can to limit the tremendous rate of growth of spending. That's the task in front of us. And the HCA remains committed to supporting you in that effort and making recommendations in line with that. And we look forward to many hours of meeting with you over the next couple of weeks. Thank you.
Thank you very much, Mr. Fisher. I think with that, we can turn to Southwestern Vermont. Mr. D, the witnesses are Dr. Dobson, Mr. Laba, and yourself.
That's correct.
And I'm sorry, is it Laba or Laba? How do you pronounce your last name?
It is Lapa.
Laba, great. All right. If you could please raise your right hand and I'll swear the witnesses in. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
And just for the court reporter, we need verbal answers.
Yep.
Yeah,
I got
do.
Mr. D. I didn't get Mr. Laba and Dobson.
I do. I do.
Okay, great. Thank you.
Thank you. And thank you for being here. We appreciate it. It's nice to see you all again. Mr. D, I'll turn it to you.
Okay. Well, good morning, Chairman Foster. Thank you. And it's good to see you. And we also thank the board members, Holmes, Lunge, Merman, and Walsh for your time this morning and time through this entire process. I know it's a major undertaking. Also want to thank Mike Daltreco and Mike Fisher for their comments, which are greatly appreciated. And we appreciate the opportunity this morning to present our 2025 budgets. You know, as certainly Mike Fisher outlined and Mike Daltreco, these are extremely challenging times in healthcare, and SVMC is continuing its transition in our health system operation, especially as a new member of the Dartmouth Health System. You know, certainly, you know, we are faced with many challenges and risks in our budget, and we also will highlight what we think is some opportunities in our budget as we continue to transform ourselves to a more stable financial base. And certainly our last 3 years have been a challenge after the fact that we went through a period of 12 years of relatively very consistent financial performance. But we're continuing to focus on community need, and we're focusing on initiating services that you hear about today that increase access to care for the underserved. We are trying to put a major institutional focus on primary care and also the needs of women and children. And we're also migrating into mental health services. So these are all things which we think in our community, they're very significant needs. So with that as a brief intro, let me just run through some additional background information. Next slide, Bob. Again, our presenters today, myself and Bob Laba, and Bob will introduce himself when he comes up, but he's our new Chief Financial Officer. He came to us by way of the upstate New York area. Been here for a little less than a year, and this is his first rodeo going through the Green Mountain Care Board budget process. You all know Dr. Trey Dobson, who's been a mainstay for our hospital for a long period of time, and Jim Roy, who's also familiar to our controller. Next slide. So by way of background, this is just an optic in terms of give you a sense of our health system, which really covers 3 states. So what I think noteworthy here is that our volume of patients now is about 30% of our volume comes out of state. And that's an increasing trend. And certainly we're in the southwestern corner where we're 12 miles from Massachusetts and about 5 miles from New York. So we clearly have border issues that we deal with every day. Next slide. Quick profile of our hospital. You know, we're over 100 years old. We're not the oldest hospital that's been incorporated, but we're probably still the oldest physical plant in the state. We're trying to play a little catch-up ball and do infrastructure upgrades. As I indicated, we're serving 3 states, and we have a medical staff of about 200, 150 active staff. You know, it's a tremendous medical staff, all 100% board certified. We have about 1,200 employees, and we continue to strive very hard to provide high quality care. And you know, certainly from our CMS star rankings over the last 3 or 4 years, consistently a 4 or a 5. You know, our nursing service clearly is a very strong point for us with a magnet designation, 5-time magnet. And also what's been recent, and just in the last month, we've been named the Lantern Award winner for emergency room nursing care. And that's the first Lantern Award. And hospital in Vermont and New Hampshire, and also in the capital region of New York. So we're very proud of the level of care that we're providing. Next slide. Our focus is on our strategic plan, and what drives us is our board governance structure, working closely with our executive team, medical staff, and other employees in terms of putting together a community-based plan that looks at key issues such as our workforce, our operations, our infrastructure, and our clinical services, and with a goal right now of continued system integration into a larger system, which we think will help to bring the scale that we need to meet the needs of our community. Next slide. And I won't go into real detail here because it really talks about the key areas of our plan. But if you look at the far right chart, it's what we're really evolving towards is a population health model that focuses less and less on fee for service and focuses on the total needs of our community with value, driving the cost of care down and increasing the outcomes, high level of quality outcomes for our patients. That's our vision. We're on that journey. We're still early on in it, but we think we're making progress, and we think with our involvement with a larger system, we can help to reach that vision sooner. Certainly working through OneCare is an important piece of that also. Next slide, please. And the centerpiece of our longer term strategy is our integration into the Dartmouth Health system. And as I reported last year to you, we are the six member hospital in Dartmouth Health. The seventh one just joined a couple weeks ago in Valley Hospital in New Hampshire. So again, as I mentioned earlier, our ability to work together with other institutions, share services, share our overhead in terms of our operations, and trying to continue to drive down administrative costs is one of our goals here. Next slide. And let me ask Trey just a comment on this slide, because I think it's pretty important from our strategic direction and with our clinical services being a driver here.
Yeah, good morning, everyone. So I'm going to try to use real examples here, and throughout my parts of the presentation, my conversations with community members and patients in our system. So let me just start. Let's look at this left side of your slide where it says SVMC is developing into a regional referral hospital of the DH system. And I would just add regional referral hospital for this region outside of DH within Vermont. A lot of people don't realize this, but if you have even a simple injury, let's say you fall and you have a hip fracture and you go to one of the hospitals in Vermont, maybe a smaller hospital that doesn't happen to have orthopedic services available, the transfer and acceptance at another facility is not clear cut. It is almost unheard of for it to be a protocolized aspect, unless maybe you're within the UVM system and they have something set up. And so what happens is an emergency physician gets on the phone and just tries to find a place that will accept that patient, which is often at a tertiary care center outside of Vermont. And that is for something like a hip fracture, that's just really not best use of resources. But that physician is going to do the best they can to get the patient the care they need now. So SVMC has opened up, it's actually on our website, and we've distributed information, and we're also within the DH Transfer Center to be a place where if we are capable of doing that service, we will accept that patient into our hospital and take care of them. And, it's been great since we started that process. It's been about 9 months. And we've, had dozens and dozens of patients come in to our system. We can accept, between a third and a half of those who call. The other ones, typically do need a service that we don't have. But, that's a third of transfers that would probably go out of state or at least be in a higher cost area. And the same is true for outpatient services too. We have dermatology that we're trying to expand. We have some services that aren't offered at all facilities. We believe we can enhance those and increase our catchment area from, as you can see on the slide, around 75,000 to 125,000. That's not just a guess. That's actually based on data from a third party who analyzed that. You may have heard of that because we did that about 18 to 24 months ago, and I believe we presented that data last time. On the right side here, this is an example of some of the services we want to expand. And I want to caution that this is both outpatient and inpatient. So in oncology, we have a robust cancer center. We're looking to expand both the footprint and the staffing. And the reason is straightforward. There is demand. There are patients that leave our area for oncology that want to stay here. So another example, I was just at an event the other night where I spoke with a local person in government who said she loves our facility. Unfortunately, her husband is being treated at Dana-Farber, and she used the word unfortunately. She likes the service there, but she wanted him treated here, and she couldn't get in. So we have to expand those services. And think about the cost to Vermonters for that person to just have to go way outside of the state for their care, something we could provide here. Same is true for inpatient dialysis. I know you've been kept abreast of the efforts to, prevent all of these patients from being transferred. We have an outpatient dialysis unit that's actually one of the rare and few hospital-owned dialysis outpatient units. It's actually high quality, high functioning. You don't have the for-profit entity involved, and we believe we can be doing some inpatient dialysis as well. Again, instead of transferring those patients to a center, often out of state, higher cost. Same is true with cardiovascular. We're going to be expanding to have some vascular services here. Right now, a majority of vascular patients, and there are a lot of them, travel to Albany for procedures. Many of them are minimally invasive and can be done at SVMC. Of course, we couldn't support a full-time vascular surgeon or service because there's not that many patients. So this is a perfect collaboration with the medical center, Dartmouth-Hitchcock Medical Center, to have physicians come do procedures and see patients in the outpatient rather than having those patients travel elsewhere. By the way, none of these services that we talk about are additional services that would not happen otherwise. In other words, this is not an increased cost. This is a savings. Here's a classic example. A gastroenterology patient that needs an ERCP, a term you've probably heard of. It's to remove, gallstones. And they're going to get it anyway. It doesn't matter whether we offer the service. This is not an elective type procedure. So they're going to go out of state to get it. If we can expand our services, become this regional referral center, offer those services to patients, at least on some part-time, if not full-time basis, it should save, first off, it saves money, but second, it really saves the patient and what they go through. Mental health, the same. We are, looking at an inpatient adolescent psychiatric unit to try to help defray some of the burden across the state. And surgical services. Let me just give another example. We have to send patients away for urologic procedures. We have one urologist, but we need two. We need to expand the service. We need robotics for urology in order to recruit in. And these patients would get their nephrectomies, whether or not we offer them, typically, again, out of state. So we can offer nephrectomies if we can have two urologists, and that's our goal. And we've done it in the past, prevent people from traveling. Let me just say a few other things in that regard. I'm going to talk a little bit about primary care, but I'm going to save that for another slide. But just two initiatives. These align, they align with Act 167. They align with the primary care AHEAD portion of the AHEAD model. We're still on task to create a family medicine residency in Bennington, Vermont. It is years away because it is quite an effort. It would actually be a Dartmouth-Hitchcock residency located in Bennington at SVMC. You've got the power of a facility that has over 50 residencies and fellowships. So we don't have to, create something that we haven't done before, but yet the location will be here at SVMC, and that should definitely benefit after a number of years, not only our immediate health service area, but Vermont as a whole in having primary care physicians present. And then another problem that we run into, and all facilities do, is as we try to create teams of physicians and advanced practice providers like nurse practitioners, physician's assistants, we have to have a place where these brand new advanced practice providers have additional clinical time and additional clinical experience. And right now, that's just not the setup in many locations. They come out of training, and then they are thrown in to seeing patients without, good support. And what happens is they end up leaving. So we are expanding our internal medicine practice, changing it from internal medicine to adult and pediatrics, called primary care, doubling the footprint, and that will allow us to bring in new advanced practice providers, match them up with a physician, increase the panel size, and take care of our community. So that's it, Tom.
Okay. Can we just go back, Bob, for 1 second? So on these services, just to emphasize what Dr. Dobson was saying, the more we can keep Vermonters local here, we are saving the health system of Vermont money. And we have looked at this extensively. We've looked at our costs of our operations. We've compared ourselves to virtually every hospital within a 75-mile radius. And when you compare us to the other hospitals in our catchment area, we are the lowest cost provider. And we have good outcomes. We have very strong quality of care initiatives that has been recognized. So we feel confident that if we can come up with strategies that allow us to care for our patients, we can provide the right type of care at the right place and at a cost that's more cost effective. And I'm not saying we're inexpensive, because we're not, and we need to work hard on that. But I think we're more cost effective than the vast majority of hospitals in a far greater region. So I just want to emphasize that. Next slide. And of course, with our integration with Dartmouth Health, we're continuing to focus. And one of the major areas we're focusing on is overall administrative costs. How can we reduce administrative costs and provide and funnel more of our resources into bedside care and clinical services that meet community need, and areas of supply chain, areas of IT, human resources, compliance, risk, financial services, administrative services, patient transport, all things that we have specific initiatives that we're focusing on right now as we speak with Dartmouth Hitchcock of how we can provide as good or sometimes better services at a lower cost. And that's a major focus of ours. Next slide. And then, as we continue, and we've been with Dartmouth now for, we've been working with them, by the way. I think you may know this for over a decade as an affiliate member, but now as a member hospital, it's a different level of discussion, a different level of commitment and investments and integration, and all with the eye of how we can provide better local services. And this is not about shipping patients up to Lebanon. This is about how we can care for them locally. And that's all what, Dartmouth is, their problem is they're over, they run 100% occupied. So they have capacity issues that are real, and they're working hard on trying to fix those. And part of that is us, there's many Vermonters in their beds that don't need to be in an academic medical center for their care. They need a strong community hospital. And that's the role we think we can fill. And that's where we're working closely on. So it's keeping patients local and reducing out migration, and then looking for opportunities to interconnect. And one of the keys is, as this bullet point shows, is our migration to a new EMR platform, which will take us several years, but we'll get there. And that's the Epic platform, which we think will play a major benefit with our integration and also providing community services. And continue to expand our telehealth, which we're one of the most wired hospitals in the state for telehealth services. I think we have close to a dozen applications right now. Next slide. We need to be financially solid. We need to be sustainable. And our Thrive program is all about how we transform our health system, right sizing how big we should be, and making sure we create the right innovation value and evolution. And it's a program that we have launched in the beginning of the year. We're reaching out to all our staff members. We're looking at many initiatives. We have at least probably now close to a dozen major task forces looking at how we can reduce our expenses and making sure that we're providing services that will allow our community members to stay close to home here. And this is not a one and done. This Thrive will go on forever here. It's how we can, become as cost effective as possible, but as high quality of care in terms of what we render to our patients. So it's not a program, I guess it's really more of a culture that we're trying to focus on. And I think, we're making progress, but we have a long way to go. And I think we have many opportunities. Next slide. Oh, I think that may be, okay. So, and this is just some of the results to date with our Thrive. We're trying to increase our access and we're making strides there, but we have a long way to go. On any given day, we have probably close to 1,300 patients waiting to get in for services and care. That's much too high. And we have teams working on this, how we can increase our access for patients. Again, as we strive to become a regional referral hospital. We're doing a tremendous amount of work on 340B. A lot of that is with the Dartmouth Hitchcock team. They have a deep bench of people who work on this. We do not, to be honest. And I think with their help, we can continue to make sure that we remain eligible as a 340B provider and provide services through the 340B program that we could not provide on our own. And a great example is our telemedicine program. We're spending over $1 million a year on telemedicine. We're not getting any reimbursement for it, but we think that's the right type of service to provide to our community, and we think it's vital. And other services such as our transitional care nursing, which has received national reviews on it. It's been named a national best practice by the American Nursing Association Magnet program. Those are the type of investments we're making through our 340B program to reach out and provide services to our community. And we're moving down the road of providing mental health, behavioral health services, which we know will not help us financially, but there's a need for it. So our board is making that commitment for us to migrate into those services. And we'll be coming forth to the Green Mountain Care Board in the future for some of those services to ask for your approval. And then we're focused on major expense initiatives, trying to become as a benchmark hospital in terms of not only our quality of care, but our costs and our expenses. And we're making improvements in our Thrive program, as you can see here, by reducing overtime and administrative FTE reductions and discretionary spending, all things that we think we have room for improvement, and we're making those happen, and we're putting them into our budget for 2025. So that's just a primer in terms of some key initiatives. I'm now going to pass over to Bob Lava, our CFO, who's going to go into the details on our budgets, operations, and how we think we're trying to meet the Green Mountain Care Board benchmarks as we go forward. So Bob, I pass it to you.
Great, thanks, Tom. Good morning, everybody. Just want to do a real quick introduction since I'm a new face to the crowd. As Tom mentioned, I'm coming to Southwestern Vermont from upstate New York, where I was the CFO of a hospital in the Adirondack Park, which has very similar challenges to the Vermont operating environment, with the lack of growth of population, with the aging population, all very, very similar to what we're facing here. I have strong history ties to the state of Vermont. My wife's family's from Vermont. My son is in a couple of weeks going to be going to UVM starting his sophomore year of college. So the success of healthcare and the state of Vermont is deeply personal to me, and presenting this budget with that in mind. So we're going to start with our 2025 budget. Quick and executive summary. As an executive summary, we really developed this budget with 5 guiding principles in mind. Everything that we discussed to add to the budget, we ran by these 5 principles to make sure that it fit in with what we were trying to achieve. The first principle of staying as close to the guidelines as set by the Green Mountain Care Board. We take affordability and sustainability very seriously and want to make sure that we are able to provide the services that we need to for the community, but also maximize the affordability. Improve operating performance. We, as Tom mentioned earlier, we've had a long history of a strong operating margin. Post-pandemic, that has been challenged with the new operating environment that many hospitals around the country, especially rural facilities, are going. So preparing a budget that is financially affordable, but also improving operational performance is key. Increasing access to care, as Tom and Trey both mentioned, we need to have the care provided to the residents close to home. This not only is good for the patient, but is very good financially for the state. Enhancing the value of care for our patients. This is better outcomes at a lower cost. So this is with the goals of increasing access, higher quality at a lower cost, are central to our number 4 guiding principle. Achieving these 3 things is not easy. Often these 3 things work against each other. So this is a challenge that we are facing and are working forward. And as Tom mentioned, we're also continuing the Dartmouth Health integration as the 6th member hospital, which we feel will offer significant improvements financially as well as clinically for our patients. As we develop the budget, 3 main themes emerged. The first is improving access to improve access for the patients and reducing the outmigration of those patients to other facilities out of state. Integration, which is a multi-year process. 2025 in the budget is a transitional year. There are no major material changes to our services offered. Finally, financial recovery. We're going to continue the work of the Thrive Plan, which currently we project our fiscal 2024 operations to be about a 1% operating margin, and expand upon that for our fiscal 2025 budget to be about a 1.6%. Next slide is the graphic representation of our last 11 years and how we have that history of a strong financial performance. In 2022 and 2023, as a result of coming out of the pandemic, a little blip in the performance, but have turned that around in 2024 and are setting the stage for what 2025 will bring. As a summary of our financials, our 2025 budget, net patient service revenue at about $210.5 million. This is a 3.5% increase over our approved 2024 budget. We're going to go into a little bit of details later on the breakdown of that. The other operating revenues, this is about a $4.7 million increase over the projected. This is a pretty significant area of focus for us. The major item there is the 340B program, which we'll talk about. Finally, operating expenses. We just want to point out here that we are holding our total operating expense growth to less than 5% as compared to our last year budget. So bringing our bottom line to about a $3.6 million operating margin, or about 1.6%. Every budget, as they're prepared, there's always risks and opportunities with the assumptions. Go through some of these top risks. First is the 340B drug program. This is, the statutory intent of this program is to enable covered entities to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. That's exactly what we're using 100% of the savings that we realize through this program. As Tom mentioned, every facility is not automatically eligible for this. Eligible facilities need to meet certain amounts of patients that they care for, and that are covered under Medicaid, as well as SSI benefits under the Medicare program. So this program is designed for hospitals that are caring for the most vulnerable population, that in order to increase access to services for that. It's listed as a risk because every year when we file our cost report and looking at the percentages that we have in order to maintain eligibility in the program, it is always a risk that we'll be staying in the program or not. Wage index reclass. So this is another risk that we are doing. Wage index is part of our Medicare rate calculation. As it was presented yesterday, this is one of the major reasons why we took a couple extra days to really review our budget and resubmit a redesigned budget. We are continually watching our wage index and how that affects us, and anticipate reclassifying next year when we're able to. Staffing is also a risk. As you'll see, we have no RN travelers, but staffing, it always remains a risk of what's going on in other areas of the state, as well as in the capital region, which is our main competitors for staffing. Finally, financial assistance. As we work the changes through the laws of the changes for financial assistance, we're watching how that will financially impact us as an institution. On the opportunity side, revenue cycle opportunities and improvements are always there. We're just making sure that our documentation matches the great work that the clinicians do, so that we get credit for all of the work that that they put in for the patients, as well as shared services with Dartmouth Health, looking for expense savings and then clinical improvements. Quickly summary on the 2025 benchmarks. The Green Mountain Care benchmark of 3.5% net patient service revenue growth. SVMC's budget meets that benchmark. The benchmark set on commercial rate growth of 3.4%. SVMC's submitted budget is slightly above that at 3.8%. Just want to make sure that point out that is with a 5.4% charge master increase on about 70% of our charges. So that is what is needed in order to get to that 3.8% commercial rate growth. Finally, our operating margin of 1.6% is within the benchmark set of greater than 0%. Net patient service revenue growth, again, within the benchmark, about 3.5%, which represents about $7.1 million for SVMC next fiscal year. That's made up of volume increases, commercial price increase, a modest Medicare increase, and then an expected increase in both bad debt and financial assistance. Our operating margin, once again, is over zero, so it's 1.6% or $3.6 million. As I mentioned, this is 2025 is a continuation budget as our integration as a member hospital with Dartmouth evolves. There aren't any material changes in the services that we're offering, and we're going to continue to work to make sure we find every efficiency and create financial improvement as we can. We do feel that a 3% operating margin is required in order to be sustainable. We need to be able to reinvest in our property, plant, and equipment, invest in our IT resources, so that we can transform the way that we deliver healthcare. We also need to reinvest in staff and providers. Can't do this without an operating margin. We're not alone in this feeling. I recently read an article published by Deloitte about margin, and where they really emphasized without margin, the ability to fulfill your mission is eliminated. In order to operate, you need to have a margin in order to be able to reinvest in the facility. They also mentioned how transformation takes even more margin in order to be able to take the risks and be able to transform the system. The one benchmark that SVMC's budget is slightly higher is our commercial rate growth. So we're going to take a little time here to talk about that and what SVMC is doing in order to limit the growth. As I mentioned, the charge master increase of 5.4% on about 70% of our charges is what brings us to that 3.8%. We are not increasing our charges on our professional fees. We are keeping those at the current level. That is the majority of that 30% that we're not increasing. We feel that this really supports and it works in alignment with our population health strategy in order to get more people into primary care, seeing that healthier community, and eventually bringing less costs. That's the theory anyway, the healthcare theory. So changing patient behaviors is also a key part of that. But working on that. SVMC is a low cost provider, so that also provides us less opportunity to cut expenses out of this increasing. At the same time as we're increasing access to care. I'm going to skip to a slide, from the Bartholomew and Nash report that was presented to the Green Mountain Care Board yesterday. I think that this just helps identify how SVMC is a low-cost provider when compared with our peers. You can see that the SVMC's amount when compared to the peers for price is pretty much right on the line, and as a cost, we're in the crosshairs. And we are not an outlier when compared to our peers on both price and cost. So what is SVMC doing to limit this commercial rate growth? First, we're reducing our total administrative expenses. When looking at our administrative expenses as a percentage of total expense, we're decreasing by about just under 1%, about 7.7% compared to our approved 2024 budget. This is a reduction in our IT costs. We are reducing some administrative salaries, which is bringing about $600,000 less expense in this budget, and also reducing some of our marketing costs. Administrative costs, that we are capturing in this are billing, transcription, HR, financial services, insurances, and other non-clinical services. I'm going to pass it over to Tom to talk a little bit about the investments we're making in our workforce and the culture that we're also instilling.
Thanks, Bob. And certainly, again, I know we are very proud and fortunate to have our clinical workforce here at SVMC, both certainly our physicians, our providers, our nurses, our other team members. And we're trying to build pipelines here. And we've had support from the state to do that, which is tremendous. Our chief nursing officer, Dr. Pam Duchesne, has been our leader here. And certainly, I know people ask me all the time, well, how are you guys getting by without travelers in nursing? And my answer is not easy. It's a very challenging process, led by our nursing leadership team who do things that oftentimes aren't being done elsewhere. I mean, they work the floors when necessary. Pam you'll see her on all different shifts, being out there. We have a tremendous model of self-governance here with our nursing team in terms of where they help to dictate the the environment they're working in, different systems and approval of policies and protocols. So this, and yeah, again, we try to recognize our staff, and we need to actually pay more. I mean, I wish we had a higher pay scale, and it's something that we're striving to do for our clinical and our non-clinical teams here. But again, there's no secret silver bullet here. This is a lot of hard work. There's a lot of dedication, and we have an engaged staff. We just did a press gaining survey, and the engagement level here at SVMC is very high. And it's really because I think we have a tremendous team of leaders who work with our employees and work closely to focus on the patients. And this is a patient-centered model here. It's all about the patients here. And so I think it's something which we're going to continue to focus hard, keep that culture here in place, but realize that it doesn't happen easily, and there's also limitations on what you can do in this environment, and we're working together to continue to keep our costs at a level which is more affordable, but also realizing that we need to do better, and we're striving to do that.
Great. I'll pass it over to Trey to talk a little bit about our expanding access to care.
Great. And, these are just some examples here. The first is in our new emergency department, we did create this. It's a 5-bed unit for those patients that are suffering with a true crisis in mental health. And, I think a lot of places have built similar facilities. We had since we were building a new emergency department, we did it with modern technology, modern amenities. But, look, beds are just beds. Really, it's how do you support the patients during these stays, which everyone is aware can be from several hours to several days. So what we have is we've actually staffed it appropriately. That costs money, but it is also, of course, the right thing for patients. We have an activities coordinator throughout the day who helps make sure that those patients that are able are getting outside walks, are getting exercise within the facility, and have access to books and other things to do while they are awaiting placement in an inpatient psychiatric unit, if that is determined to be the best location for them. But then there's also the treatment component. So many places, I believe, have these nice holding areas, I'll call them, but no treatment occurs. And so that's really not in the patient's best interest. I can't imagine one of my own family members with a broken leg just hanging out and waiting for days with no treatment to that broken leg, even if they needed to be somewhere else for the definitive care. And it's the same, it's true with mental health. So, our designated agency, which is called United Counseling Services, very close with our organization. We work hand in hand. They round every day on the patients, help our emergency physicians in providing, both medical, but also other treatment for these patients while they are awaiting inpatient psychiatric transfer. We are expanding and formalizing an alcohol detox program. And let me just explain that because I know a lot of people aren't aware of what this means. Unless they've actually gone through it themselves or had family members or close friends go through such a program. Sometimes when people are alcoholics or have a trouble with drinking, they actually need an inpatient medical unit rather than going straight to a inpatient or outpatient rehab. That's not really the case with other substances, but with alcohol, there is a danger of harm when you go through the withdrawal process, delirium tremens, as many of you know. So many hospitals will admit patients like that, but it's kind of ad hoc, depends on who's working that day and other circumstances. So we're really working to formalize this program where patients that present, if they meet those criteria and they need the inpatient services, that we provide those to them. And again, a formalized, protocolized way that incorporates standard of care and best practices. Now, the next step is where someone goes after their 2 to 3 days of inpatient, and that we are working with community partners to ensure access to those, whether that is an inpatient rehab facility or an intensive outpatient. place or outpatient at home, but with services during the day. We mentioned the family medicine residency, again, years away, but the planning starts now. Just for everyone's awareness, that's probably about a program that basically has 4 to 6 residents per year. So 3 years for family medicine is about 12 residents providing care. These are individuals who become primary care physicians right then for their patients. And then once they graduate, the patient then sees the next person coming up. That would be tremendous service in itself for access here in our community. And then, of course, once they graduate, if they stay in the area and practice medicine. And then finally, I mentioned expanding our primary care site so that we can have teams of physicians and advanced practice providers taking care of patients. And let me just emphasize that again so that everyone understands, I think a buzzword or a buzz phrase is we want everyone practicing at the top of their license, right? You've heard that. We should all practice at the top of our license. But frankly, just getting a license is no longer what's necessary. The amount of experience that people get, especially since the pandemic, in real clinical care is limited. And they come out and they know that and they tell us. And if we can't support them in providing that oversight, then we lose them quickly, or they go to bigger cities where they can find these areas where they have the ability to gain more clinical experience. We can do that. We can provide that oversight. We just have to restructure and develop teams of physicians and advanced practice providers. Typically a 1-to-1 model or even a 1-to-2 model will expand access for the community. It helps these individuals gain that experience so they can practice more and more on their own. I did want to go back up real quick on the partnering with United Counseling Services. Some of you are aware of the program that's a psychiatric urgent care. It's gotten a lot of acclaim in this area. In fact, the Wall Street Journal covered this. It's called PUC for short, Psychiatric Urgent Care for Kids. It's where kids can go, taken by the police, taken by their parents, if they're in crisis, but not end up in an emergency department. This is a facility that's owned by SVMC, but is staffed and operated by the designated agency, United Counseling Services. It's incredibly successful. Kids can go here right from school, right from their crisis area, not have to go to an emergency department, and receive the type of healing that they need. Thanks. Go on back to Bob.
Great, thanks, Trey. Finally, our fourth strategy for limiting commercial rate growth is our shared services with Dartmouth Health to reduce costs. Where appropriate, we're shifting administrative functions from the local level to the more broader system level. We're also expanding our group purchasing opportunities by accessing contracts under the Dartmouth Health name. This budget alone has well over $1 million of savings attributed to surgical implants, lab supplies, and those are the same supplies that we purchased last year. We're just going to be able to access better pricing and save expense. Also working through all of the different contracts that we have, as well as the negotiating ability. Finally, our pharmacy and 340B opportunities. There is a very strong team at the Dartmouth Health System level, which is helping us maximize our programs so that we can take those savings and reinvest that 100% of those savings back into the services at SVMC. Go into some of the details. I'm going to try to keep it at a relatively high level. You have all of the details in our submitted materials. But just to emphasize that this budget doesn't have any material changes from our 24 budget and our projected 24 results. Our inpatient volumes are expected about a 5% increase over our 2024 budget, and exactly the same as where we're projecting for this year. So no additional growth from where we currently are on the inpatient business. On our outpatient volume, it's a little bit different per area. These are our main areas that we're focusing on in this budget. Again, not materially changing from either our fiscal 2024 budget or our 24 projected actuals. Assumptions to our largest variances in our budget of 2025 compared to 2024. First is the other operating revenue. The major variance in this is our additional 340B contract pharmacy savings that we're able to unlock as a partner, as a member hospital of the Dartmouth Health System. Those additional savings do come with expense, which I'm going to jump down to the bottom bullet, is recorded in our pharmacy drug expense. As you'll see on our P&L, that is one of the largest expense growth areas on our financial statements, and it is mostly due to the additional savings that we are receiving in our contract pharmacies. Also, jumping back up to other operating revenue, one of a grant that we have received for our nursing pipeline, we are recording $1.2 million in revenue for that grant. There is 100% offsetting expense for that, so an additional $1.2 million in expense added as well. And finally, our locum expense for our physicians, we are keeping that projection very consistent with where we are running in fiscal 2024. Our fiscal 2024 budget assumptions were to reduce that locums, which we weren't 100% able to achieve. So we are not expecting to increase locums more than what we're currently running. Days cash on hand, currently have about 175 days cash on hand. This is including all of our investments that are held. Most of our investments are held at our parent organization, SVHC. So they're not visible on the on the SVMC financials, but we are projecting an increase in our total days cash on hand. This is all related to our assumption on market performance, and we have a 4.5% return assumption built into the budget. Our goal for our days cash on hand for our operating, which we're currently projecting to be around 6, is 30. So this is where we're focusing on our financial improvement, and in order to boost that up to 30 days, so that we have 1 month's worth of expenses on hand in the bank. Capital and debt. So this budget represents a $9 million routine capital budget. Most of that capital budget is going to be allocated to the information technology bucket. As we move towards the Epic integration, it's a multi-year process. This is the preliminary steps needed in order to get our systems ready to go in order to start that process. $2.4 million, which is mostly replacements of our clinical equipment. $1.1 million in our facilities and engineering. We do have a relatively old plant that we are working in. So $1.1 million will be allocated to the ongoing maintenance for that. We also included about a 9% contingency in order to account for the things that are may pop up that we're not fully anticipating. I also want to point out we are anticipating no additional debt being taken out in 2025. We are planning on using both philanthropy as well as equity savings for financing all of this capital. Finally, I just want to run through some of our CON projects that we are anticipating over the next couple of years. First is our adolescent psych unit. This CON was filed last February. We're currently working through the process, answering the questions. This is a $9.5 million capital project that is mostly funded by the governor's state budget, and then as well as additional equity provided by SVMC. Expansion of our cancer center. We're expecting to file this in the fall of 2024. We're currently wrapping the bow up on the business plan as well as the fundraising efforts. We're anticipating this to be a $21 million capital project again, funded 100% through philanthropy and equity from SVMC. And finally, our electronic health record replacement. We're expecting to file this CON in fiscal 2026, multi-million-dollar project to switch from our legacy system over to the Epic system. And most of the funding of this will be paid by the system, Dartmouth Health. So in closing, this budget that we're presenting, we are confident that we're going to be able to maintain and increase access for Vermonters while maintaining affordability and sustainability for the hospital. And just want to throw it over to Tom and Trey if there's any closing remarks you want to make before we open it up to questions.
No, I thank you, Bob. And so certainly not. I think we'll just answer your questions you may have. Thank you.
Sure, and I just had a couple of things. The budget we worked really hard on. I look forward to the other initiatives with the Green Mountain Care Board, AHS, Vermont Medical Society, VAWS. I think there's other ways that we can really support these hospital budgets to reduce cost. And I'll just name some of them. These are going to people that practice medicine can really relate to these. We have to support our doctors and our advanced practice providers in resource utilization. What we can do today is so much greater than what we could do 10 and 20 years ago. And we feel pressured to do those things when sometimes we know that the benefits aren't there, but the societal expectations are. And that really does increase costs. There needs to be a focus on end-of-life care and how we can preempt some of the extraneous costs that are associated when the patient themselves wouldn't necessarily want those, with the proper discussions ahead of time. And that takes support of primary care. It takes time, but it's worth it. And then critical care times, the same. The stuff that goes on in critical care, often the patient wouldn't want it, but there's nothing there to say anything different. And so a lot of dollars go to critical care that really don't benefit the patients. And then finally, complexity is a great enemy in medicine. The amount of things, just looking at oncology, the complexity is so great that we lose a lot of appropriate care and cost due to that complexity, and how we work together and not point fingers at different areas in order to get that under control. So I think those are real things we can work on and help reduce costs in Vermont.
Yeah, Chairman Foster, I just want to add one other thing. Is on a closing comment here, is that this is not an excessive budget. I mean, I struggle long and hard about coming in with a 1.6% margin, which is less than what we need. But we continue to focus on a transitional plan to get back to where we have to be in the not distant future. This is a budget that we're doing without in many areas. So I just want the board to know that we're trying to stay within guidelines, but also meet community needs. And we have a strong tradition here. I mean, the hospital was named the American Hospital Association Rural Hospital of the Year a few years ago in the area of community involvement, community collaboration, and we take that very serious. So this is a challenging budget for us. It will continue to be a transitional budget, and our focus is to meet community need, but also to maintain financial sustainability and stability, and that's what we're striving for. But we also realize that we're not going to be able to catch up in 1 year. So again, we thank you for your time and attention here and your support, and we look forward to working with you, and as Dr. Dobson said, other state agencies, as we continue to try to transform our healthcare system to a different model. So thank you.
Thank you all for your presentation and your comments. I'll turn to Member Lunge in the event that she has any questions.
Thanks. Thanks so much, and thank you for your presentation today.
Can we just take down the screen here?
Sure.
Yeah.
That's fine. I can let you know if I need you to pull up a slide or something.
Okay, great. Thank you.
So I wanted to just to ask for a little bit more clarification around the commercial rate request change. So based on what you said today, and I apologize if this was somewhere in the written materials and I missed it, but it sounds like you made a request from Medicare to reclassify your wage index, and that was not accepted. Is that right?
Not entirely correct.
Okay.
It's just that the change in the wage index of the region that we are currently in.
Yeah.
We were not able to reclassify out and into a higher wage area.
Got it.
And we were working on that through the first round of the budget where we assumed we would be able to.
Okay. And when would you typically ask for that from Medicare?
So typically this is every 3 years. So we will be filing our wage reclass for fiscal 2026 soon.
Okay, great. Thanks for that clarity. And so it sounds like in your budget, you had assumed that you might be able to get that reclassification sooner.
Correct.
Okay, great. So in terms of, I'm trying to track it throughout your submission, you highlight, which I thought was extremely helpful, some of the areas that you're focused on for reducing expenses. And it was helpful to see your slides today that summarized some of those. For example, your reduction in admin expenses connected to reducing IT costs, admin salary and FTE reduction in lobbying and marketing. I just wanted to run through also some of the savings that you articulated in the narrative to make sure that I'm tracking those into the right category. So it sounds like you're expecting some efficiencies also from the affiliation with Dartmouth. And I saw in your narrative that you had identified 500,000 for supply chain and purchasing. Does that sound correct?
Correct. So it's about $500 to $1 million in the total supply chain purchasing area, made up mostly of the supply implants as well as purchasing of lab supplies.
Okay. And then I also thought I noted at one point you indicated there was some prescription drug savings.
Right. The prescription drugs are mostly on the 340B, related to the 340B program. So
Yep.
in the 340B program, it's all outpatients. So that's no drugs used on inpatients. So
Okay.
That's purely on our outpatient business.
Okay, great. I'm just looking at my notes here. Great. All right. And then I see the other 600K is on your slide that I had noted from the amendment. Did I miss anything that wasn't on your slide 24?
I don't believe you missed anything. I think it's just important to know that we are, we're constantly looking at our administrative costs and trying to be more efficient and, utilize the limited resources that we have to make sure that we are fully aligned with providing high quality care at the lowest cost.
Great. Thank you. So in your narrative and in your presentation today, you've spoken a lot about how you're trying to reduce transfers through your affiliation with Dartmouth, telehealth, a number of different initiatives. Do you have any way that you document that? How are you going to know that you're successful?
Trey, do you want to take that?
Yeah, we actually track, Robin, all of the calls that come in for inpatient transfers, in other words, to SVMC.
Yeah.
And that's how I came up with a number of about a third, that we're able to actually accept. We wish it was higher than that, but those, we get calls for people that need stuff like cardiothoracic surgery, and unfortunately we can't do that. But we
Yeah.
definitely receive calls for everything from community-acquired pneumonia, where one hospital just doesn't have the staff to take care of them, to something more complicated where we actually have that service available, like urology. So we keep that. It's an internal document. I mean, you know, we share among ourselves, but there's no real external sharing of it. But be happy to grab those numbers for you. I don't want to say what they are right now because I just can't remember them off the top of my head. I
No
remember the
worries, yeah.
percentage.
Okay, yep, no, that's helpful. So it sounds like you are trying to create yourself as a referral center, so bring in folks from outside of the region. You're trying to maintain care locally, so also preventing transfers out. Do you have a way that you're able to kind of track migration of local patients? I will note that, well, let me ask you the question and then I'll. So do you have a way that you can get a sense of out migration from your region?
We can, Robin. It tends to be a look back though. So it's
Yeah.
not, you know, real time concurrently, but yeah, we have different software applications that we utilize, firms that we can track our out migration, and we're doing that right now.
Okay, yep. And where do you see most of your out migration?
Oh, by far, it's the capital region.
Yeah, okay.
It does
That
depend,
would make
Robin.
sense in terms of the geography.
Yeah,
It does
I mean,
depend on the
it's-
service as well, you know, which
Yeah.
service you're talking about. So inpatient, acute transfers, as Tom was saying, that's almost all Albany. Vascular is almost all Albany, but there are some individual needs that people go to DHMC or other locations for.
Okay, great. I had a couple questions around the border information. So it sounds, so I looked at your narrative on page 24, and then there's also the spreadsheet, which is confidential, so I won't get into the numbers of that spreadsheet. In terms of the expenditures associated with boarding, this question was really just a clarification question. It sounds like in being in calculating the impact of patient boarding, you're able to do that, but and also parse out diagnoses. Am I getting that correctly?
For
For the boarding patients. I'm trying to get a sense of, can you tell why folks are boarding based on your data? Sorry, I didn't ask the question very clearly. I need more coffee, I guess.
I can just say a few things to that. It is difficult and manual, Robin. If
I
we
see.
look at diagnosis, that just doesn't matter. For example, you know, Dave will know this, but you know, you could list a diagnosis of sore throat, and you're why is this person waiting then for you know, boarding? It's because they actually have, you know, an oral pharyngeal carcinoma that needs an otolaryngologist, and we don't have that. We can say anecdotally, though, it's for all the reasons that you're aware of, and it kind of
Yeah.
varies over time. So it's transport, it's acceptance in an acute care facility, and it's acceptance at a skilled nursing facility. Those are the, you know, three main reasons.
Thank you. And then my last question about borders was, do you have a sense of the insured status of your borders? Like, do you think the payer mix is about the same as your hospital in general? Is it more Medicare patients, more Medicaid patients? Do you have any sense of that?
I don't have any sense off the top of my head. We would have to do, you know, again, that manual deep dive to get that.
Okay. Thank you. Let me just take a quick look at my notes to see if I missed anything.
Robin, would you like us to get back on that question so you have an answer?
No, I don't want to cause you manual work. I was curious to know what was easy or difficult to know about the boarding situation based on the data. So at this point, please don't go do a bunch of manual work. But thank you for asking. Nope. Okay, I think I am good. Thank you very much.
Thank you.
Thank you, Robin.
I had just a couple. I'll try not to take too long. On the transfers and trying to keep the care and expand the volume of care at your hospital, do you distinguish between transferring to other hospitals or to community providers?
You mean, do we keep a log of where exactly they go? Owen, is that what you're saying?
Yeah, well, what I'm getting at is part of our healthcare reform goals are to get care out of hospitals
Right.
to local community providers. How do you make sure that when you're keeping more care at the hospital, you're not impacting care being delivered to more community-based providers?
Yeah, Owen, I would say with certainty, 98% of these patients are needing inpatient services, not outpatient services that we're doing. Otherwise, we would work to find that. And so back to the border things, there are patients that are in our emergency department, and the intent is not for them to go to an inpatient facility, but it is to get care in an outpatient facility. So we don't really include those in the transfer because they are ultimately not transferred to a tertiary care type facility. But what we're talking about is, for example, let's say a patient needs a nephrostomy tube in their kidney because they have such bad buildup in the kidney due to a cancer or a kidney stone. And if we don't have a urologist to do that, then we have to transfer them again, usually to the capital district. So we're trying to ensure that we have those services when appropriate. We're never going to have neurosurgical services because that's too rare, but something like urology, that those are available here, and that those patients can be supported in our intensive care unit with the use of our own hospitalists plus our telemedicine intensive care relationship with DHMC, which is now approaching probably 8 to 10 years of use, 6 to 8 years at least, and that has helped keep patients local rather than transferring them.
And Owen, I'm not sure if this gets to your question or not, but we did in the last year get certified license to offer swing beds through the federal government. So we now are a swing bed provider. So, then that was driven primarily by the fact that we can't get all these patients in the nursing homes when necessary. So at least we can designate them to be a nursing home patients within the walls of our acute care setting. And that helps to a certain degree, but it doesn't solve the problem.
And then you testified about SVMC being a more affordable hospital than others. And it sounded like you said also that the majority of lost care from your region is going to Albany.
Right.
How do your costs compare to Albany?
We're lower. Yeah, I mean, primarily the hospitals that we refer to are Albany Medical Center, Samaritan Healthcare, and St. Peter's, and we're lower than in all those areas. Now, I wouldn't say on every single diagnosis we'd be lower, but when you look at it in a composite way, we're definitely lower.
Yeah, no, of course. And what data sources are you looking at to make that cost comparison?
I can get you the name of the program. Our director of planning, Jim Tremarchi, has been delves into that pretty deeply. So we can get back with the name of the program.
I want to apologize for the informality of our office space. We don't have an office. So I just heard my St. Bernard trudge behind me, and I noticed you had one in your slides. So I just wanted to.
There's a long story there.
We're not informal by choice. We just don't have a formal office space right now. So I apologize for that. Yeah, if you could get me the name of that, I'm curious what the program is, and we have a number of sources we're looking at, and that would be helpful. The only other question I really had was on provider productivity, and in your workbook, you provided some benchmarked data in provider productivity. And there's a number of service lines that looked low, 20th, 15th, 25th percentile. Is there opportunity to increase the productivity at some of those that are, significantly below the 50th percentile? And is that in the plans?
Yes, I can comment on that real quick, Bob, and then maybe you can make a comment. So first off, I hate to jump on the data, but just for everyone's awareness, this is national data. So if I'm a primary care physician in New York City, it is very different. My ability to refer patients to specialists down the street it's really lickety split, right? And in Vermont, I don't have that ability, so I am dealing with those. I mean, I'm not a primary care physician, but if I was, I would be dealing with those. I would be making those phone calls. I would be calling and speaking with the specialist. So that impacts the number of the productivity, which, by the way, is just measured, relative value units, which is not a great way to measure how effective is a physician or advanced practice provider at providing care. So that's the data. But yes, there's always opportunities. It's very transparent. We've worked over the past several years to make this data transparent to all of our physicians and advanced practice providers, but more importantly with the office staff, because even though we act like this is the productivity of an individual, that's wrong and actually causes people to be very defensive. It's the productivity of the system in taking care of a population. And that's actually what I meant earlier when I was talking about aligning advanced practice providers who are sort of just coming out of training with an experienced physician or other advanced practice provider to really increase the volume of patients we can take care of. There are, of course, people that are very good at their job and people that aren't so great. And so we try to support those individuals as well.
And if you're able to increase some of those service lines, what's the plan to address if your budget is approved and you are able to make up some increase there? What's the plan to address the overall effect on your budget order?
Meaning that our revenue will increase because of the added access. Yeah, I think that as we move in this transitional year, maintaining this 1.6%, there's a lot of risk in the budget. So by increasing access, sure, that means additional net revenue, but there's also a lot of risk, and in our current models, we're not anticipating that increased access to increase more than what our net patient revenue growth is projected.
And Owen, I would just comment, and I think this answers your question, it may not. In addition to revenue, of course, there's other metrics. There's the productivity metric we just talked about, which I also mentioned the limitations, but there's days until appointment, those access metrics that actually, your group has defined something specific. We would always follow something similar, but now we're following that directly. As well as anecdotal information coming from patients themselves and community events we do. So those are all compiled together and will help us know how effective is our access.
And by the way, we really didn't get into it. I'm not sure why. We didn't get into the whole description of what we're dealing with here with the insurance companies and their denials, which, if you look at the growth of that is significant over the last few years, and that's a huge risk for us that we're very nervous about, especially on the Medicare Advantage programs, which they're really kicking the stuffing out of us here. So I think the risk is huge there, and could very well offset some of our access initiatives that we're trying to work on.
In your long range planning for some of the service lines that are low, is there any consideration to reducing any service lines?
Be very honest, we don't do a lot of esoteric service lines. I mean, it's pretty much bread and butter here. Trey, I mean, you could help me, but I'd say the answer to that question is no. But we always are looking at, I mean, we're going through the Oliver Wyman study, And, they raised some questions about some low volume areas. So we're certainly looking at those. There's not a lot of them, to tell you the truth. I mean, we don't do a great deal, but Trey, anything you want to weigh in on this one?
Yeah, I mean, there's a few smaller ones. You're right, Tom. There's not larger ones, at least right now, that we've identified. One would be, we do have a part-time plastic surgeon who does some cosmetics, but really is a small volume and doesn't really support the practice, and he's retiring soon, and so that won't be replaced, at least in its current mechanism. The second would be, general surgery volumes have been down across the state and also nationally, and they didn't rebound like we anticipated. So we've repurposed, which is kind of a strange word to say for a surgeon, but had some of the surgeons focus on other things that were out migrating, like endoscopy. Patients were going elsewhere, so they've stepped in. If they needed additional training, we help support them, and making sure that frankly, that they are working to the level they want to be working, and that is the case.
Thank you. And the only other question I had was on the, I think it was on the Thrive, you don't need to bring it up, but the Thrive slide, you had amounts of money you were looking to reduce in the interest of cost containment. And it had $500,000 in overtime, $2 million on salary adjustments, discretionary, et cetera. Is that where you currently are, or is that the target that you're trying to achieve?
Those are our fiscal 2024 targets that we are well on the way of achieving.
Gotcha. Okay. And then are there other targets you're planning in this budget, and what are they?
So a lot of these targets that we have in 2024, we baked those into the assumptions of our 2025 budget. But we are continually looking at new initiatives that we will need to put into place in order to maintain that 1.6% operating margin.
Right.
I'll give you another example, Owen, is this, the whole, I mean, the service contracts, we have millions of dollars of service contracts. And, and we hit a target this year of about a $500,000 reduction. We think, when we're looking at every one of them, and there's literally hundreds of them, to see, can we renegotiate, can we eliminate, can we change those? So that's just another example that we are going to carry over into 2025 in terms of our Thrive initiatives.
Okay. If there's any targets you're setting for fiscal year 25 beyond the ones that you've baked into the budget that you've achieved, if you could send us an update on what the goals are, that'd be really, really helpful. And I appreciate the conversation around efforts to contain costs very much. I have no other questions. If any other board members do, please go ahead.
Could I just chime in with a few, mostly for Dr. Dobson, for Trey, regarding expansion of some of the specialty services and procedures. So you mentioned vascular and cardiac services and procedures today, and I think in the narrative and a presentation down in Bennington recently. What are some of the cardiac and vascular services and procedures you're looking to expand into? And I guess I would also add, you mentioned ERCP services potentially, and robotic surgical services, and thanks.
All right, let me see if I can answer this. So David, so we're not talking about, big surgeries. These are minimally invasive vascular surgeries that would not be done, 5 days a week at SVMC. This is a vascular surgeon from DHMC coming down and doing outreach, maybe 2 to 4 times a month, along with the clinical outpatient aspect. So, we're going to start off where they come, 1 or 2 physicians are already just got medical staff privileges. They'll be down doing an office day and a surgical day a month, and then that'll probably increase to about, like I say, 3 to 4 days per month. We anticipate that's the volume that would, support our community needs. So not a lot, but definitely the numbers there suggest that benefit to the patients. There's also, so as far as cardiology, we're not setting up a cath lab, but we are looking at how we can do some cardiac CT to prevent patients from leaving for catheterization that turns out to be unnecessary. Also a little bit more advanced echocardiography that our cardiologists could read and patients go elsewhere for. Same is true for maternal fetal medicine, increasing some of our technician training and software programs in the ultrasounds so that these patients going for level 2 ultrasound now, which has somehow become a standard, don't have to travel so far for those. Let's see, robotics, we already have some robotics that are going on. We know that we have great difficulty recruiting another urologist to join without robotics. It's just how they were trained. That's not necessarily true in other surgical specialties, but definitely urology and some orthopedics. We've incorporated that with working with DHMC. In fact, we took one of their robots that has been used. So it's a used machine that's highly functional and works here.
And the other question I was going to ask is, I noticed your inpatient pediatric volumes are really, really, really low. Is that something you guys are thinking about continuing or whatnot, 12 per year?
Yeah, so mostly what's happened there is I know you brought this up so that I talk about it for awareness for others, is the standards in admitting a pediatric patient have changed. When I started 20 years ago, I'd probably admit a patient every week to 2. Now you just don't admit kids. You treat them in the ED, get them better, and send them home, or they end up needing services at a tertiary care center. So that's the trend that we have seen. But of course, we have 400 deliveries per year, so the pediatricians are needed for those newborns. And if a 10-year-old comes in that needs an appendectomy and an overnight stay, we will do that. And so we want to maintain, or they need to be admitted for respiratory distress, but aren't in need of an ICU. We want to continue to admit those patients. Plus, we have we hope to have an adolescent psychiatric unit here, and there will need to be pediatric medical coverage of that unit.
Thanks.
Guess I'll jump in then. Thank you for the presentation. And actually, welcome to Mr. Laba. You've joined a strong leadership team and a very well-respected hospital in our state. So welcome aboard for your first rodeo at the GMCB. A couple questions. I do have some questions. One is around the commercial rate increase of the 5.4. And I understand it's distributed 70% of the charge master items and 0% for professional services. I'm wondering if you can speak a little bit about, how those 70%, is it basically 5.4 on inpatient and 5.4 on outpatient, or how are you thinking about distributing that 5.4%?
The 5.4% is pretty much across the board on all of the services, all of that 70% of those services, inpatient and outpatient. Okay. It would be really helpful. I know Chair Foster asked for that data of how you're comparing yourselves to other hospitals. It would be really helpful to understand that. One of the data pieces that we saw yesterday, it was the RAND pricing, as I'm sure you're aware. And if I just do a quick look at the outpatient standardized price for Southwestern compared to Dartmouth and Albany, it does appear in that, at least that one data source, that the outpatient prices are higher, inpatient maybe lower. So it would be helpful for us to understand how you're comparing your prices to some of these other prices. And as you're applying the 5.4% on inpatient and outpatient, does that create an even larger deviation on the outpatient side to your comparator hospitals? So that would be helpful for me to understand if you could, as you're following up with that. I wanted to also ask some questions about the clinical productivity data that you shared with us. I'm wondering, first of all, if somebody could explain the benchmarking. It looked like there were 4 benchmarks used, 4 national benchmark used, and it looks like there was a rural adjustment applied already to that benchmark. So I'm hopeful that you can explain a little bit more about how you arrived at the benchmarked numbers across the 4 different surveys with a rural adjustment already applied.
Bob, do you want to speak to that, or you want me
Go
to
ahead,
speak
Trey.
to it?
No, go ahead, Trey.
So the way, Jessica, that was arrived at is we used a third party to come in, named Pinnacle, to come in and make that recommendation. We could have chosen just one, like MGMA. There's limitations in doing that, and that was their recommendation. It does apply a rural change, which affects some of the productivity numbers, but it also affects some of the compensation numbers, and that's kind of what the goal was behind that. Also, being now a member with DHMC, it was clear that the benchmarking they were using was focused on academics, which is quite different when you have residents and others in there. Productivity benchmarks are extremely useful and also extremely problematic because they vary from service line to service line, as I mentioned earlier, and I'm not trying to make excuses, but what we do is we use this as a model, we adhere to it, but we pay close attention to what's going on. And the goal is to support the individual provider, but also the practice to ensure that their productivity is appropriate for what they are doing.
With that in mind, do you have specific clinical productivity goals by specialty area then?
We do. We try to be at the 40th percentile or higher. Let me just give you an example, and I want to be careful here that I'm articulate. A productivity measure also includes how much is done for a patient, which is important, but how much is done to a patient. And we want to be careful that productivity numbers don't get in the way of doing what's right for a patient. You know that a lot of these productivity numbers, I'm sure you're aware of this, but are affected by additional things done for patients that there's no measure in the productivity of whether that was necessary. And so we don't want to be, I don't think any organization wants to be the highest productivity, because that's probably implying there are things being done that aren't necessary for a patient. And it's why we don't use productivity metrics in places like the emergency department and inpatient services, where it's clear that those numbers can be driven up by ordering additional treatment and diagnostics.
Okay. It seemed as though, I know these are confidential files, so I'm not going to give the numbers, but it seemed as though there were some areas where you were expanding services, hiring more providers, while the productivity levels were, say, for example, below the 40.
Yeah, that's correct. We have other initiatives beyond Thrive that have worked to increase those productivity numbers. And again, it's not just the physician or advanced practice provider. So if we are adding people, it's due to access. So we have to add them anyway, even if the productivity is low, while we at the same time work on the productivity, which we are. And just to give an example, back to the primary care, some of those things are investments in additional blueprint investments, which we are participating in the expansion, and that will help, quote, the productivity, because it allows the physician to not be involved with long conversations and phone calls that are very important, but also could be done by someone else while the physician then takes on a new patient. So I guess in short, Jessica, it's parallel. It's not just hiring new people. It's not just increasing productivity. I think we have to do both to work on the access.
And just one final question along these lines. You'd mentioned compensation and your third-party consultant helping with the productivity and the compensation. Is there alignment with the compensation and the productivity? So, for example, in practices that are below the 40th percentile in productivity, is there compensation below the 40th percentile? How does that work? The alignment between the two.
Right. So the overall model, the answer to that would be yes. There are certain services where the productivity cannot be, there's just not enough volume to support a productivity above 40%, yet there's no way we could have that service, and it's critical to the community. So let me just give you an example. Radiation oncology in our practice, you need about 4 to 5 oncologists, 3 to 4 oncologists to support one full-time radiation oncologist. We don't have that here, so our radiation oncology volume is less than that, but it's certainly, definitely needed in the area. Patients would not be able to receive cancer care. So in order to support having that physician, even though the productivity is below 40% percentile, he is paid at that 40th or 50th. I can't remember. I think he's at the 50th percentile in order to
It's
keep
okay, we
him.
don't have to, yeah.
Yeah.
Okay, so I mean, in some ways, this speaks to a lot of the Dr. Bruce Hammery work, right? In trying to think about regional referral centers, centers of excellence, and ensuring there's enough volume to support the necessary specialists.
Yeah, Jessica, in that, since you brought it up real quick, the numbers that were listed in some of those initial reports are unrealistic for primary care panels. 4,000 patients, nobody has metrics like that. And I think Bruce wasn't trying to say, everyone needs to do that. I think what he's trying to say is, look, in order to support the access needs that he predicts in the future, you're going to need a team, surrounding that physician and advanced practice provider to be able to take care of that many patients. And that is doable.
Yeah, I think I was referring more to his specialty services, centers of excellence, in terms of ensuring enough volume to support the numbers of specialty providers, given the call schedules, all the things.
Yes, agree.
That are required. Yeah. Let me just think if I have other questions here. I do have a question, and I want to. It's around the quality, and I'm. I so appreciate Southwestern has won tremendous awards over the years, and I think well-earned awards over the years for the quality, for the community engagement, for a lot of areas of excellence. And I just, we're trying to figure out, how do we think about quality at the board? I think the public is trying to figure out, how do we think about quality? And some of the metrics that are out there are CMS star ratings, they are Leapfrog. And I'm just wondering if you can speak to, I know there's been some, reductions in star ratings across the board in Vermont, actually, some reductions in Leapfrog ratings across the board in Vermont. And I'm wondering if you can just speak to, how should we interpret these reductions in stars and Leapfrog A's, B's, C's? And what information should the public have to assess quality?
Trey, do you want to?
I'll start, and maybe Tom can jump in afterwards. First off, everyone loves the quality metric source that gives them the highest value, and then doesn't like the ones. So if you do well in U.S. News and World Report, that's clearly the best source. So we struggle with that too. I will say I believe CMS actually incorporates probably the best data source. It's not perfect by any means, and it does vary depending on what services your particular hospital offers. So when I say that, I think it's pretty good for larger community hospitals and larger centers. It may not be as great for smaller centers. So that's something to keep in mind. So I think Leapfrog, same way. I think being open to those. There are some, I don't want to say, but there are some others that are not really as representative, and they just tend to take data from other sources and put them together. And so I think you have to be careful in that way. It's very hard to measure outcomes. So there has to be both the objective, but there's a little bit of subjective in there as well. I think in Vermont, we can do things like measure access, and access itself, although it doesn't sound like it's actually a quality because you don't know the outcome. It is true that access correlates with outcomes. So if there is good access, there should be at least a trend towards better outcomes. And that's shown in other countries where they have better access to primary care, and then they also happen to have better outcomes.
So does Southwest do anything? Do you have any initiatives in place given the recent adjustments in the Leapfrog and in the CMS star ratings?
Oh, absolutely. We have a spreadsheet. It's so long. I trying to get to the end of it's impossible, but it has all of the CMS measures that SVMC it applies to. I can't remember. It's like 80 out of 140, something like that, ballpark. And where we were last year and where we are this year, what went up, what went down, and how do we focus efforts on all of them, of course, but prioritizing the ones that make the most sense, that we feel like we can move, and that, frankly, matter. There's some that they don't seem to matter as much as others, and so we're going to put our efforts, because our resources are limited, of course, towards the ones that matter.
Okay, thank you so much. Appreciate it.
Just a couple quick things first. Bob, from a fellow Northern New Yorker, welcome to Vermont. We should chat sometime about our favorite national park. And to go along with what Jess said, you've joined a strong team. I've done this my third time. I enjoy hearing what's going on at your facility and hearing Tom and Trey. And thank you for the presentation. That was all that I was going to say until Trey mentioned a moment ago the link between access and outcomes and how they're related. That's something that we haven't gotten deeply into here at the board, but the research on that's really strong. And it seems to be that it's a signal of system friction. Right? When access is a bad problem, there's a lot of friction in the system, and that friction extends and disrupts other quality components. And so I appreciate you bringing that to us at the board, and I appreciate knowing that you're on it. So thank you very much for your presentation today.
Thank you.
Anything from the healthcare advocate?
Good morning. Yes, we have a few questions. I'll ask a few questions, and then Sam will have a few questions as well, Mr. Chair.
Great.
Thank you, Southwest, for the presentation. Appreciate it. And we do have, I will focus on the bad debt and free care and Act 119 issues, and Sam has some broader questions. First, I just want to recognize and appreciate Southwest did a very good job of complying with Act 119. Your plain language summary is quite good. Your measurement of your asset, residency, income measurement are all in line with the law. We have one concern, and I'll bring it up, and that is that, and I'll explain it a little bit. Income verification, the reason why the law states that people can supply their tax, their previous taxes, and in the event that they don't file taxes or their taxes don't represent their income, they can supply just other documents, is so that that people don't face a daunting list of, 8 different documents they need to produce in order to apply. And so that's one place where I think it makes sense for you to take a look at your application, and because I think it could have that impact. And I don't think it's in strict compliance with the law. But on the whole, I really wanted to say, express an appreciation. You are amongst sort of the top notch of hospitals that have done a good job.
Thank you. I appreciate that. We will take a look at that concern.
So the reason why, well, I guess I want to recognize that in 2023, your bad debt to free care is, for every $1 of free care, you had almost $3 of bad debt. So I don't really have a question about that. I just want to note it. But I also want to just at least glance at your 25 budget on those factors. You're estimating a fairly significant increase in bad debt in your budget, from 6.1 million in 23 to 8.5. And I wonder if there's something going on that you're tracking, or how it is that you arrived at it. Do you have any insights as to why that number, you're projecting that number to go up?
As affordability becomes an issue, we are anticipating more movement to patient responsibility type plans, higher deductibles, higher co-insurance plans, and with that comes an increased amount of bad debt, and the ability for the healthcare organizations to collect that from the patient directly. So that was the main driver for that assumption. There are others as well, but I appreciate your renewed focus on bad debt charity and charity care, financial assistance. That's financial assistance is something we take very seriously. We have staff working with our patients very closely in order to make sure that that they qualify, and the overwhelming majority of patients that apply do qualify, and we work through the process. So we will continue to look at that.
Great. I think I appreciate your answer. It's a good one and a concerning one, a reasonable one and a concerning one. Yeah. I think I don't know what the right ratio is. We often cite hospitals that achieve a 1-to-1. I didn't say this up front. I just want to say it really clearly. We, of course, like you, will watch carefully uncompensated care. We don't want uncompensated care to go up. We're hopeful through these efforts and through your efforts that the bad debt that's out there that would qualify for free care is captured or better captured. And so that's the reason why I'm focusing on the ratio. I mentioned the hospital that achieves a 1-to-1. I don't know that that's the right number, but I'll just say, concerned about 3-to-1. And I would welcome, I think, we need to keep talking about how to do a better job of reaching people and making sure that they get the support to fill out the applications for free care.
Absolutely, and I think we have staff on payroll that their job is to ensure that patients get free care, and so this is an expense that we're bearing in order to reduce our revenue. And whether it's classified in bad debt or charity care or financial assistance, that this is care that we're providing to patients that we're not getting paid for. And as a hospital, we're required to see every patient that walks through our door, whether or not they have insurance or not, and we gladly do so. And that's it becomes a problem when we are not reimbursed for those services at any point. But with that said, we take our mission very seriously and work to stay within the guidelines and meet those regulations set in order to provide care to everybody.
Thank you. Sam, do you have questions?
Yeah, thank you. Good morning. Can folks hear me okay? Great. Thank you for the presentation. Sam Peisch with the Healthcare Advocate. I wanted to follow up, Mr. D, with something I believe you said. I just want to make sure I heard it correctly. Did you say that you don't get reimbursement for telehealth? And if so, could you elaborate on that a bit more?
No, our telehealth services, by and large, I'm talking primarily our inpatient service, telehealth services, or ICU, our ED services, psychiatric. They're non-reimbursable at this point in time. So we contract with Dartmouth-Hitchcock to provide those services, and we have a contract fee for those because they're incurring expenses, but they're basically non-reimbursable.
Okay. And I know you spoke a bit about 340B revenue and how that was offset by higher expenses. Could you just elaborate on like the higher expense side? Because that was confusing, at least to me.
Sure. So there's two different factors of the 340B program that Southwestern Vermont takes advantage of. The first is the savings on drugs that are used on our outpatient services. So these are drugs that are used in our infusion center predominantly. So we're able to purchase that, or because we qualify servicing a high Medicaid population, we're able to qualify for discounts on purchasing. So those are the savings that we're able to record. On the other side of the program is our contract pharmacy program, where we're able to contract with pharmacies to fulfill prescriptions on scripts written by our outpatient providers. So if a provider goes and sees one of their primary care provider, they write a script that's filled for a 340B eligible drug that they fill at the CVS or any of the pharmacies, the local pharmacies that we have a contract with. There is savings to be had there as well. Those savings are reduced by the replenishment cost, because if that pharmacy fills that prescription, we have to pay to refill their inventory of pharmaceutical drug. So that was the expense that's offsetting the savings that I was talking about.
Okay, thank you for clarifying that. I appreciate it.
Very confusing program, and probably much more confusing than what it needs to be.
Yeah, no, I appreciate that. Thank you. Something you said in the narrative, and you don't have to go to this, but just in case you want to cite it or look it up, it was on page 19. You talked about health insurance premiums for your employees and offering, you basically said you were going to cover and keep the premium at no more than 10% and absorb some of these costs and provide a lot of free care for certain services that employees have. I'm just curious, you said those costs were absorbed, which was interesting to me. I'm wondering if you quantify that in any way and how you arrived at the decision to do that.
Yeah, absolutely. I mean, if we look at we are a self-insured plan. So the services that we're providing to to our employees, do have a direct cost. If that employee goes to Albany Med, we're paying those, through our TPA, we're paying those claims to Albany Med. So, as we have brokers and actuaries that we do all the different studies on what our premium equivalent is going to be, because we don't have a premium based plan. It's a self-insured plan. So those premium equivalent expenses were that the actuaries presented were significantly higher than a 10% increase from 24 to 25 based on their models. We decided to, in order to reduce the burden on our employees, to limit that to a 10% increase.
Okay, thank you. And last question, and this is towards the end of your narrative. You talked about not being able to fully utilize OneCare waivers due to star ratings of regional skilled nursing facilities. Maybe this is a question for you, Dr. Dobson. I'm just wondering if this is something that, is there anything an SVMC can do about that, or are there any regional efforts to improve that, or is that really out of your control, unfortunately?
Well, I would say definitely we try to partner and help folks, but unfortunately it is a little bit out of our control. I know specifically, you're saying things like the 3-day waiver, but it has to be a 4 or 5, and that is really problematic. We'll try to help folks when we can, but our resources are focused here. Certainly dialogue improves outcomes if we can just keep talking about it. So
great.
Definitely the patients suffer. I mean, because they're just in the wrong place, right? So it's good to focus on.
Yeah, Mike, go ahead.
If I could just jump back in, Mr. D, I'm confused. I don't doubt you one bit, but I'm confused by the inability to bill for telehealth, given all of the ongoing conversation in the legislature about expanding coverage and reimbursement for telehealth. We don't need to go into it more here, but it just is confusing to me and maybe warrants some follow-up.
Yeah,
Mike, I can just explain real quick.
What I'm really referring to is the inpatient telehealth services, which are expensive. It's there's some insurers cover for outpatient at a much lower rate, but it's the inpatient, which is really the major piece of our telehealth program. It's all tied into our rate, so we don't get separate reimbursement for it. And it's very expensive. I mean, it's a great service, and we support it, and we're making investments, but it doesn't come free.
Thanks.
Yeah, that's everything for me too. Thank you.
Great. We have nothing else, and we appreciate your time this morning. And we will adjourn and go off the record till we start back up with the Copley presentation at 12:15. So we'll take a break till 12:15. Thank you.
Thank you. Thank you very much.
Thank you. Appreciate the time.
Thank you.
We're off the record.
Hey guys, I can see the mouse moving, so I'm assuming that somebody on the Green Mountain Care Board is out there doing that.
Yes, that's correct.
Okay. Yeah, I just wanted to let you know that we're online.
Thank you.
Hey, Kristen?
Yes.
Yeah, I got a question. With your, actually, I think we're being recorded right now too. That's kind of cool. With the way that the Teams meeting's set up, it's going to have this look to it, just we're going to be able to share our screen. Is that correct?
That's correct.
Okay. And so we don't have control of like, you can see the participants on the right-hand side. So it will just be that little block that I'm looking at in the middle of the screen.
I'm not sure what you're looking at, but yes, if you click on people on the top, it'll pop up on the right-hand side.
Yep.
Yep. And
See,
so
right
I'll
now what
stop.
I'm seeing is I see all the people on the right-hand side. Is that you controlling that, or is that
Yes,
me
because
controlling?
I'm sharing. Yes.
Yeah. Okay. Thank you. That's what I just
You're
wanted to
welcome.
understand. All
Yep.
right. Bye.
Maggie, are you back? Or sorry, was it Michelle or Maggie? Mixing up.
Sorry, it's Michelle. I keep
Michelle.
getting muted. I have a separate mic that I mute, but I'm here.
Sorry, I mixed up days.
That's okay. M&Ms, you know.
And is Mr. Wooden here?
Yep. Yep, we're here. We're here.
Okay. Hey, Joe. It looks like your video's off.
Oh, yep. Turn it on. Thanks. I'm going to zoom in. Great.
Great.
Mr. Wooden, as you have presenters speak, can you just ask them to state their name for the court reporter since we have everybody in one room?
Sure. Yep. That would be great.
Thank you.
Ann Bongiorno.
I'm sorry, what was that name?
Ann Bongiorno.
It's in the materials. It's in the materials also printed.
Okay, no problem.
Great.
And Kathy
Michelle,
DeMar.
I'll get those to you.
Okay, thank you. Kathy, sorry.
DeMars.
Okay.
Joe Wooden. Jeff.
I'm sorry, after Mr. Wooden, who was that?
Jeff Hebert.
Okay.
Donald Dupuy.
Sam Allaire.
Okay.
Okay, great. Michelle, we can go back on the record.
Okay, we are back on the record.
All right, we'll resume our hearing, and next we have Copley's presentation of its budget. We've allocated about 45 minutes for the presentation, and then we'll have board member questions that follow. Public comment today will be at the end of all the presentations. Mr. Wooden, could you and your team raise your right hand so I can administer the oath? Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
I do.
Great, thank you. Nice to see you all. Thank you for being here, and I will turn it over to you for your presentation.
Okay, I'm going to share the screen, guys. Please let me know if there's an issue. Can everybody see the screen?
We can, yes.
Great.
Great. Thanks, everybody. Really appreciate being here. Myself, Joe Wooden, I'm the administrator. Jeffrey Hebert's here to my right, Chief Financial Officer. Dr. Dupuy, the Chief Medical Officer. General Surgeon is also with us, and Sam Allaire, the Chief Nursing Officer. In addition, we have two board members very interested in these affairs, always asking good questions and helping, steer the organization. Kathy DeMars, who's a nurse. She's chair of the board of trustees, and she's also the CEO of the Home Health and Hospice Agency, which is next door to the hospital, which is lovely. And Bongiorno, she's also an RN, and she's the vice chair. So we like to do overlap and make sure that we have consistency. So Anne wanted to be here today. Also, she works also for the State University of New York. So that's who we have here to answer any questions or to chime in on some of the presentation. Today, we've got basically 5 things we're going to go through, just an overview, some discussions about the strategic plan, finances, which is going to be the majority of it, as well as sort of aspects of quality and access. Thanks very much. Our mission, we've changed it now and then, which is fun, but we like to consider just exceptional quality care close to home. These are just some examples of the camaraderie and the teamwork and the fun that we try to have together, whether it's the 4th of July or dressing up for Halloween. We do a lot of stuff. People work very hard here. And you see those 5 attributes about everything from lifelong learning to service excellence. It's a very common. Next picture. So,
Not seeing the slides.
My apologies. I'm so sorry to interrupt, but I'm having audio difficulty hearing. Yeah, you sound like you're underwater. Am I the only one hearing this?
no, I'm hearing that. I'm not sure who's talking. In fact, it's so unclear.
Right. Okay, thank you. Mr. Chair, can we try to fix this situation?
So I can hear Copley and you totally fine, Michelle. I think it's Dr. Merman. Dr. Merman, why don't you send me a message if you need something now, and we'll let Copley continue. And
Okay.
send me a message, and Joe, I'm sorry, you can keep going.
Okay. Can everybody see this slide where it says the annual report?
No.
No.
Oh, sorry,
No.
no, we see the budget presentation.
Oh, okay. It's a Jeff thing on our end. Thanks, Dave, for bringing that up.
All right, guys, I'm gonna go. Can you guys see the annual report right now?
Yes.
Page 5 up there. Yeah. Okay, so I guess we missed those first few. It's fine. We're on page 5. So this is just a lovely picture of Copley going back to 1932, 92 years old, great old OR pictures, etc. And here's our hospital. I always love to think about this. One of the things that I collect that don't cost anything, I always ask people who are new to the organization to get to know, hey, do you collect anything? I collect antique Vermont hospital postcards. I have a collection of all the old postcards from hospitals. Here's one I've had for years for Copley, which is kind of fun back in 1932. It's now owned by the designated agency, which is great, the Will County Mental Health Services. And we did find an old fundraising materials on the right where people would bring food. I know in these old hospitals, the community involvement was so important that they would do food drives to help fill up the pantry in the root cellar of the hospital. Saw that at Gifford when I worked there. They had a root cellar still in the hospital. And sometimes they do linen drives way back then to get sheets and blankets and towels for patients. So I just thought that might be interesting. So not sure what happened there. Okay, we're just a small independent nonprofit, one of 8 critical access hospitals. Service, I throw this up, service area population. It's so hard to determine, but I know when we do a lot of data and graphs, people just quickly use the word service area, which is a denominator. Both the numerator and denominator come out to that performance issue, but the HSA definitions are really unusual. So for us, for orthopedics, it's certainly much greater, but for that birthing center, it's much smaller. So it's kind of interesting. I'm a big fan of data, and I'm also a big critic of data. I just want to throw that out. We have emergency department visits, employees, paychecks, overview of services. I wanted to bring this up because it will relate to a future slide presentation. What services do we provide? How do we describe them? So we have a number of surgical services, cardiology, anesthesiology, birthing center, OBGYN, oncology. So it's kind of interesting. What services do we provide? How long have we provided them? How is that going? It's a discussion that we think about, certainly strategic planning wise and others, and we've been prompted to do that, but I thought that slide would be helpful for you. The patients that we serve, we're a little bit unusual. We only serve about 60% of the folks in our county. Now, is our county the service area? Again, we use these sort of broad descriptions, but 32%, give or take, are Chittenden, Washington, Caledonia, Orleans. So we serve a lot of people outside that come to us. So that's great. Next slide. Again, sort of interest. How do you come up with a total for patients you serve? And anytime you look at data, we look at inpatients, outpatients, the description of each is important. Inpatient is clear, outpatient, there's a whole discussion about what you count as an outpatient patient experience and then the total. So just as interest, one of them noted is Burlington. South Burlington, below that's Montpelier, Essex Junction. And I love the one at the very bottom, which is other Vermont towns, of which we have 183 inpatients and 16,000 outpatients. And then there's some out of state, out of country. Just kind of interesting what we do and what we look like. So that's all. Slide. When I look at the overview, we are, again, one of the 8 critical access hospitals. There's PPS hospitals that are between sort of an academic medical center and ourselves. I think it's important that you look at them that way because we're different given our size and some of our reimbursement through Medicare, but also distance from each other, length of stay requirements. There are some restrictions around the CAH that we have to be aware of. So next slide. Always like to show this one. We are humbly 3% of the hospital spend, which is fine and understandable. The UVM is about 50%. The network is somewhere around 62%. But we're small but mighty. I think that's the way we describe ourselves. Next slide. I always like to bring this up because it's a trivia question you can ask people. What's the second largest hospital that serves Vermonters? And it turns out it is Dartmouth Hitchcock Medical Center with about $400 million in net patient revenue. Look up above, which is really kind of interesting. I know they're on the other side of the river, but that's pretty close. So, and we appreciate them in a variety of ways. So, next slide. I want to go into just a quick discussion about the strategic plan. We've done a strategic plan from 22 to 24. We're actually going to not continue to do another 3-year plan. We're going to do that next year. So we're kind of like a high school student that's a little lost. We're going to call it a gap year. We're not lost and we're not trying to find ourselves, but we've got a lot on our plate. I think the first plan that we did was excellent, but for this year, we're going to stick with the current plan, make some modifications in the board, nothing huge. And then next year, we're going to work on the 26 to 28 strategic plan. Next slide. So in all of the previous plans, you can't read those, but you could if you grabbed it online and make a copy of it. But the 4 issues are financial sustainability, quality, workforce, and culture, and keeping care local. We spent a lot of time getting to those 4. I think they're probably somewhat timeless and their importance to us. The order makes a big difference and had a lot of feedback and some people being disappointed who weren't really part of the process. Understandable. Like, why would you put finances first? Shouldn't your call be to quality? And it's like, of course, quality in the care that we serve is paramount. However, of late, we've just realized we're really fragile and we've got a lot of financial issues with operating margin, which you're aware of. And that's why we're going to talk about that, because at the end of the day, if you run out of money, it changes everything. And as they say, when funds are short, table manners change. I think that might be a Vermont term, And so we're trying to prevent that and trying to be professional and respectful. So next slide, related to the strategic plan, we had the Oliver Wyman report that's been presented in many events. Dr. Bruce Hamry and his team, I think, have done a wonderful job. I think it's been helpful, and I can only offer my thanks and appreciation. It is an outside person just objectively looking at you, and he is sensitive enough to hear stories and to spend time with people, but at the end of the day, him and his team do look at the data, and they do look at what's going on in Vermont, and they're very concerned about our financial viability, all of us. So I thought it was great, and I love the fact that it says the point is to support hospital transformation. And we're going to go down that road and also ask that the Green Mountain Care Board in future discussions, as well as the Agency of Human Services, help support us in that process. Because going from point A to point B, and point B looks great, you should be at point B. If it was that easy, we would already be there. So we're going to need help, any of us that go through these transformation discussions, particularly about services, maybe locations, expenditures, what you do and why you do it. And I know our board is very queued up for this discussion. It's going to take a lot of heartfelt consideration, but I appreciate that. I do want to pass on this next slide. I only bring this up because it's my personal experience. I'm sure I'm the only one that appreciates cognitive overload. That's just for me, but I want to share it because my therapist said this would be helpful for the group. My brain can process a certain amount of information presented in different methods. The brain processes the information you gather each day from reading a newspaper, looking at the Becker's reports, looking at consulting reports from the state of Vermont, individual department reports, following directions on a map, or also budget instructions, requests for information, thousands of spreadsheets we fill out, and having conversations with a friend. So today, I guess I'll consider this conversations with a friend, but we all suffer with cognitive overload. I know yesterday, Jeff and I sat in some of your presentation report. You had five reports that you went over. And, you know, the report on hospital transformation, really appreciate that. The Act 167 report, we're going to take that seriously. And we're not going to keep reading more and more reports, but we do know that we need to possibly look at what we do, why we do it, and what can we afford. But I think I suffer like perhaps just maybe one or two in the room that the chart on the right, the more data, the more confusion I get. But thanks for listening. That was helpful. Next slide. So in the strategic planning process, and even prompted by the thought of transformation, during COVID, there was some good parts of COVID. We got desperate enough to work together locally. There was 6 of us, the hospital, two large primary care offices, the nursing home, the mental health agency, and home health and hospice. So it was great. Those are probably the 6 largest providers of care in our community. There's 26 total local agencies below, but it did cause us to work together, and it still has given us benefits. And we have relationships, and we talk about things. We also have just embarked about doing that with the New England Collaborative, which is really exciting. And that's the sort of logo on the right. And there's 3 of us that are part of that. But we're also going to try to apply some of the efforts of the New England Collaborative locally to our six agencies that are working together. So it's kind of interesting. One of the differences in this collaborative is that we're going to try to consolidate, save money, standardize, consistency, everything from labor, purchasing, contracts, policies. But we're also going to try to work locally and say, if anybody wants to share those things. I know with COVID, we all desperately needed to know, what's your policy? What are you doing? Are you letting staff in the doors? How many masks are what are you doing in terms of negative rooms or HIPAA filters? So anyways, next slide. Yep. The collaborative, some of the challenges we're working on are keeping care local. That is sort of interesting. It was previously part of our strategic plan. It didn't cause this, but this is what we all struggle with. Reducing costs, managing workforce, and a host of other issues. But in the text on the left towards the bottom, it says, the goal is to remain independent by creating an interdependent framework that achieves scale and efficiency for each of us. And we've been doing some of that. We've been sending staff to some of the other collaborative hospitals. We've been sharing some providers with the other hospitals. We've had board meetings, lunches. We invite them to our strategic plans. We've actually really are so interested as we move forward to get to know each other and to know how can we help, because we're sort of like-minded given our size and the challenges. So I think that's great. That slide just shows that we did get some positive thrusts, which was great. Chris Doherty from Brattleboro, myself, and Peter Wright from Northwest Medical Center all sort of signed up for that. So it's been exciting. And again, we'll probably see if people can help us to come together, because again, making transformational change takes encouragement from others and sometimes a little advice, if not grant money, et cetera. The last collaborative discussion I want to have is with Dartmouth Hitchcock Radiology Services. And anytime we talk about collaboratives, we don't we don't just stick with one organization. We're small and dynamic, and we make decisions as necessary. So we probably 2 years ago started the process of looking at our radiology services, the radiologists, as well as the equipment, both our MRI, CT, other equipment. And we entered into a partnership with Dartmouth-Hitchcock July 1st as the sole provider of radiology reads. So they're going to do that for us 24 hours a day, 7 days a week. We eliminated VRAD, virtual radiology services, during off hours, commonly used in most small hospitals all across the country. There are thousands of people that use sort of VRAD. We're going to have in-person radiologists here Monday through Friday. And we're going to have much more specialized radiology access. So that's some excellent feedback. We did look at 2 other options. One was UVM, but that's not part of their business model currently, which is fine. We asked them. And the other option we had was out of Connecticut. Those are the ones that we're really interested in bidding. But I think with the Dartmouth system, we're the maybe 13th or 14th hospital part of that. I don't know, Dawn, if you wanted to add to this at all. Dr. Dupuy, our Chief Medical Officer, has been a big part of this transformation.
No, except we've been really happy to be able to use Dartmouth's radiology expertise, their national class medical center, and we've been thrilled with the quality of their work output and their ability to help us care for our patients.
And we sometimes periodically send to them, depending upon the circumstance. Primarily send always to UVM, but there's circumstances, as we have learned during COVID, where sometimes that medical center is full and we're sending to either Dartmouth or somebody is sending to Boston. So we had a lot of that. Okay, next slide. Thanks, Jeff. Finances. And I know you're going to wait to the end if there are questions, but if somebody wants to ask a question, let me know, although we can't really see that.
Joe, I did have a question. Would you say, or maybe Don, would you say that using this new radiology service reduces the need for patient transfer when the patient doesn't necessarily need tertiary care, but with VRAD, maybe you couldn't get the specific kind of specialized radiology?
I think, and Don, it will certainly help in that process, having on-site their expertise and plus their ready access to their entire radiology team. Again, that serves, I don't know, 14 different hospitals constantly, 24 hours a day. We might put our toe in the water with some interventional radiology. Not really sure, that's a possibility, but we're going to have a higher caliber of physicians on site to manage things. But your thoughts on that, Dr. Dupuy?
Yeah, I can't think of an actual incidence, but the main thing that having Dartmouth do our radiology has done is reduce the uncertainty of what's going on diagnostically, which allows us to make better decisions. So we might make a transfer decision sooner, or we might decide we don't need to, because we can in fact deal with this problem, and less uncertainty is really always better in medicine.
Okay, finances. Want to go to the least savory subject about our operating margin or gain over the past sort of 10 years. We have 8 years of actual. So we've been struggling historically. I know the 1 year we did well was because we have COVID funding, FY21, and most hospitals had that recognized in 21 or 22. But if we didn't have that, we would have again lost about 1.2%. We're working very hard to try to get out of that. I know we had a mid-year rate increase that we're hopeful that will bring us to at least a break even. We were hoping for positive operating margin, but we appreciate everybody listening to some of the data and our challenges. You look at our critical access hospital 5-year operating margins for everybody being in that same group. Some folks are struggling a lot more than others. Some of this data, I go back 5 years. Sometimes I like to look at 10 years to just to see what's going on. So we are down there on the bottom right, you'll see that Copley is for the 5 years negative about 520,000. I put note below, same order as in years past for that chart on the right. So the previous orders were Porter, Mount Scottney, so the orders sort of stayed the same. The only change is that Copley's gotten better, so we're not the worst, unfortunately, but North Country is certainly struggling, as it's just what the data shows. But so there is movement. We're usually at the bottom, and we still sort of are. So I want to share that. Next slide. I think Jeff's going to go over this. This is some material he found around the cost of care, cost per adjusted discharge. So I'll let Jeff share that.
Yeah, and if I could, I just want to do a shout out. Does everybody see the current slide, cost of care, cost per adjusted discharge?
Yes.
Great, great. All right. So cost of care, looking at our cost of care per adjusted discharge. This data was published by the NASHP. They used 2022 cost report data. You know, as we were like looking into the budget process, and what type of data we need to use, this was recommended by Boz, and I could also read this throughout the narratives that were posted, online. But what it shows is it shows that Copley's at 8,587. We're the third lowest in the state. The Vermont critical access median, the median that we really kind of focus on, their cost of care is 10,179. The overall Vermont median, looking at all Vermont hospitals, is 12,430. We also have on this chart the national CAH, which is at 14,038, and the national median, which is at 11,987. You know, when I look at this chart, you can see that Copley does offer, its care at a low cost. However, our quality is one of the most important, if not the most important, and we are able to still do that at a high quality, care level. But what I also wanted to communicate is, however, our reimbursements per Joe's, going over the operating margins just haven't been enough to, demonstrate that we've been able to cost or cover that care with with our reimbursements, and that's why we're having those low operating margins. The next slide is a slide that Joe did want me to put in. It does have Grace added to it. I excluded it because Grace was, their cost per adjusted discharge in the study was at 57,000. And so just perspective.
So Jeff wanted to just use the previous slide because you can see some level of variation. Sometimes when we don't look at the highs and lows, don't look at the data, don't really understand why something would be so extraordinarily low, which is perhaps days cash on hand or extraordinarily high, or even an infection rate or something else. So just wanted to throw that in there. Not sure if it's all accurate, but that's kind of the data that we have.
All right, the next slide was data that was supplied to us last year. It also uses 2022 cost report data. Just basically was a nice representation, to try to understand where our admin costs were to our clinical costs in regards to salaries. And so when we take a look at this, you can see that we again only looked at Vermont CAHs, and in this graph, Copley is the second lowest.
Okay. In looking at our finances, we went over operating margin, cost of care. With the margins, they've been sort of insufficient. Cost of care is some of the lowest. Capital, buildings and equipment were significantly underfunded historically. So this chart shows 11 years worth of sort of cutbacks in our investments, where at the right, it says, well, did we save $12 million when we got approved $55 million in the budget process through our board, through our assessment, Green Mountain Care Board? We only spent 42 million of it. So that's not good that we weren't able to execute on that. And if you go to the next slide, we did update this for today to add our actual performance for 22 and 23. So if you look at the past few years, 21, 22, 23, we're getting our footing. Things are getting better. We're trying to stay in that green band of routine capital goal and needs for the organization. It's great. But last year, 23, we're small enough that if we don't have a building project finish, which we had a renovation project, didn't finish because of contractors' timing and the cost of that, it got kicked to the next year. So when you run the numbers, we still went from sort of being 12 million behind, we're like 13 million behind, but we're getting better, but it's going to take time. So we're getting a lot better, but we certainly need the help and support. So slide just going to go over some cash issues.
So again, this is days cash on hand. This is another graph that we're consistently trying to present. These are the critical access hospitals in Vermont. For the 5-year average, Copley has been averaging 76 days cash on hand, which is the second lowest in the 5-year average. Looking at the FY 2023, unfortunately, Copley is the lowest at 43 days cash on hand as compared to the other CAHs. This is just a demonstration that we feel that Copley needs several years of positive operating margins to be able to rebuild our cash reserves. Another data slide that I was able to get from last year was looking at cash for operations. And when you take a look at the overall cash for operations for the CAHs in Vermont, you can see that Copley is the third lowest. The lowest is Grace at 2 million, but their cash is sort of tied up, as I understand it. And the second lowest is Springfield, but they're coming out of bankruptcy, so we're not positioned in the best place. With this, I just want to say that all we're looking to do as an organization, and again, Joe was alluding to this, is we just need to be reimbursed like other Vermont hospitals. And we also understand that we need to be able to